Good afternoon, everybody. So before we go on to the main IC, we have a very important person amongst us. So Dr. AMOD sir. So the mere mention of PG Chandigarh will not always remember his name. So he's going to deliver the first ever AIOS Dr. P. Namperumalasamy Endowment lecture. This is being incorporated this year into the program. So he's going to deliver his this first lecture on this endowment. AMOD Gupta sir doesn't need any introduction. He's in India. uveitis means his name is synonymous with uveitis, and he has been served as the dean of the PGI institute in Chandigarh. So I've been awarded a lot of awards. Amongst them, the crown is the Padma Shri Award. So we have one of the very famous Padma Shri awardee, Dr. AMOD Gupta sir, to deliver his lecture on experimental learning, the key to becoming an expert. Please, sir.
Thank you, Sarvanan, and good afternoon, everybody. It's indeed a great, humbling experience to be presenting this first P. Namperumalasamy Endowment Lecture 2020. I'm really honored by the scientific committee and the urban healthcare system to give me this unique opportunity to present. So all of us in the beginning of our career aspire to become an expert, like you have Dr. Sarvanan here, but don't know how to become one. So in the next 10 minutes or so, I shall share with you a magic wand which I used, and I'll give you the key to that magic wand. This perhaps may be the last time I ever speak in the AIOS forum. So those who wish to take away that key, you can easily take away. If I ask any one of you, how do doctors make a diagnosis? Sounds simple. But the question has vexed researchers for decades. It's highly complex. I'm sure you can look within yourself and try to answer this, how you make a diagnosis. You'll not be able to tell very explicitly what process you went through to make that, reach the diagnosis. There are three types of doctors. They are novice, not expert, and expert. Again, we don't know what's the definition of expert. Anybody who has the ability or experience or research in a given field for about, say, 10 years is an expert. Now let us see when a novice is confronted with a patient. He has had no experience of seeing a patient, and very often in our clinics, we find our junior residents and fellows taking a whole lot of time, trying to work up that patient, and we say, what the hell is going on? Neither the resident realizes, nor you as the teacher realize that what is a differential diagnosis. Now this is the first encounter. Do repeated encounters make that person an expert or any better than the first time? Perhaps very doubtful. It's not an automatic process. It's a process that you need to learn. On the other hand, and I'm sure the expert sitting here would endorse my viewpoint, and you might have read in your books, physicians used to diagnose a patient as the patient walked into their clinic. We call this intuition. So they are able, and this is what research has shown, that within seconds of seeing a patient, they are able to generate a hypothesis and then use their analytical skills to reach the diagnosis. And that brings about an efficiency. Now, how do you become an expert having that intuition? Okay. How do you? become intuitive. From where does this intuition emerge? What is this intuition? Now, this intuition, we always thought this supernatural. It's not supernatural, I wish to convey to you. This is the information which is stored in our subconscious mind. And this is the information which is gathered from multiple sources, accumulated over the years or decades. How is it organized in the brain? This again is a subject in itself and has bothered researchers again for decades. And now we have better tools to study these phenomena, okay? And tools like functional MRI to see what are the areas when you are making that spot diagnosis in a flash of a second, what is going on in your brain and what is that information stored. How do you accumulate experience? Now this is, I'm sure, all of you are familiar with this process. The patient having some complaints, coming, interacting with you, you look into his symptoms, you look into this physical exam, you have a differential diagnosis, you order some lab test, and this goes on. You do a confirmation test of the diagnosis, you order a treatment, and you send the patient home. Most of the times, my young friends, they don't want to even know the outcome. They don't know what happened to the patient. And if you keep seeing your patients in this process, which is absolutely right, there's nothing wrong with this process. But if you keep seeing this every time you see a patient, you'll remain a novice because you have not accumulated any experience from the patient. How do you accumulate that experience? Is what is this? That any outcome, wherever you have gone wrong, whether the patient done well or not done well, it has to be assimilated, integrated into your diagnostic process so that you keep on adding. I saw today one patient, another week later I saw a similar patient, it adds a third patient. You can formalize it, and unfortunately most of the Indian ophthalmologists don't like to publish a formal accumulated experience by way of a paper, because that will give you, that is accumulated experience, okay? So what I've just explained very briefly, this will take about an hour to explain in details, just I've been given 10 minutes. So what intuition is nothing but an experiential learning. In real world, we use both systems. As an expert, I make a diagnosis in a flash, automatically. And then I start analyzing, how did I reach that? What lab should I order? And that brings about efficiency, and that brings about, you use analytical skills to test and verify what you just experienced or what you just said. And now, as I refer to functional MRI, now it has shown that your analytical skills and your intuitive skills, they are stored in entirely two different areas of the brain. They are not in the same area. And this is a subject of research, current research all over the world. How about conventional learning? What we learn in medical school. What we learn in the medical school is pattern recognition. You learn in the clinics. Your teacher weaves a pattern of signs and symptoms. He demonstrates it in a patient, just like that you would do in a study shop. And your wife, when she goes, she's immediately able to say, what? This is Kanchivaram, this is Patola. She doesn't. This is a flash of a second because she has already been exposed. So anything which you know the pattern pre-existing, you have known. If it is unknown, then you are at a loss. How do you deal with that? So here's an example. Now I'll just test you for how did you learn that this is the left eye? How did you learn that this is the optic disc? Can you recall when you learned these were the retinal vessels or arteries or veins, or this was the yellow spot or macula or the background? Who taught you? You will not be able. This is intuitive. From where it has come, accumulated over the entire training period, you can't pinpoint this is where I learned it. So you recognize a pattern here. If your teacher has demonstrated you in the clinic, you recognize this pattern and you say, well, this is toxoplasma retinitis. He has demonstrated to you how to treat. You treat it, patient gets well. Next time a patient comes of toxoplasma retinitis, you are able to treat it very well. But what if there is an unknown patient? It's a major challenge. You're sitting in your clinic, there's nobody to hold your hand, and all of us have faced this situation. I'm sure all of you do face that situation where you don't know what to do. You're at a loss. Now also remember, when we see these kind of diseases, you know, these are the diseases, if you have not been exposed to the disease, you are not an expert. So you remain an expert so long you have had adequate experience in treating and diagnosing that particular disease. But you confront this kind of a disease, I'm not sure how many of you can spot it, or have you seen this, what do you do then if it's not a familiar pattern? How do you go about it? I'll just take a couple of minutes to finish, please. Okay. Most of the comprehensive ophthalmologists whom I have come across, they'll pass on this patient to a person who might know better, who might be an expert, who might have the experience of that kind. They will say, bury it under the carpet. It's nothing to do with me. I'm not going to gain anything. That's where they're going wrong, because they don't want to gain experience of diagnosing that unknown patient. So this is the difference between an expert and a novice and not so expert. An expert would go to the bottom of that patient. It should bother him. He should give him sleepless night. Why? What happened? Why didn't I be able to diagnose? So you learn to make, this is what an expert will do. He will learn how to represent that problem in a line, in one line, and two lines. Okay, using what we call semantic qualifiers. These are the characteristics. Is it acute onset? Is it insidious onset? Is it affecting the choroid, affecting the retina? Okay, is it affecting the entire eye, or is it affecting only anterior segment or the posterior segment? Okay, is it progressive? Not so progressive. Fast progression. Now, if one looks at this patient, you know, which looks superficially like a toxoplasma retinitis, but not, because it doesn't have several of those characteristics. And patient says, well, I lost my vision last 3 days. You have seen any number of patients with toxoplasma who do not look like this over a period of 3 days. You want to know how is this lesion progressed? And another 3 days and you see this. Oh my God, what is happening? This is progressing so fast, accelerated progress. Now you want to qualify it further. Where is it affected? Is it the retina going? Is it the choroid? Where is the pathology? And then you want to order certain investigations to fine-tune your characteristics. Okay, like just, you know, these examples. Like you will need to, like this particular patient, you like to use, say, angiogram to show you the presence of the lesion, or you want to use an OCT to show where it's located, is in the retina, on the choroid, or as a quiz for all of you to participate in this quiz with Sarvana's permission. This is a guy, young man, he had dengue fever, serology positive, and this is a picture I'm showing you. He went blind, and he was treated on, he was extensively investigated. I have never seen a patient more investigated, where you have the entire body PET scan done, and you have the vascular imaging done. Now, can somebody give me a descriptor for this? This is about 1 year later. This is what the picture looks like. The fundus image doesn't look much change you see, but the image below, again, is fine-tuning the pathology using fundus autofluorescence. Now, when you are trying to say, now, you are seeing this hypoautofluorescence is all around the vessels. Now, would you call it perivascular or paravascular will decide whether you will be able to reach the diagnosis. So when you're fine-tuning, you have to be very, very careful in describing, because it will take you on a tangent if you call it paravascular, but if you call it perivascular, it'll hit the spot diagnosis when you can. So, nutshell, how do you become experts? What are the other approaches? One is what I've told you, experiential learning. Learn from your own experience. This we as experts must learn from our own experience. Each patient that we see must add on to that. So what are the other options or approaches available is that you must function in a community of experts. Working alone, very difficult to become an expert. You will become a skilled, again experiential learning, a skilled surgeon or refractive surgeon or corneal surgeon or a cataract surgeon, but you will not become expert physician. I am sorry to say that. Learning environment. You have to be in the learning environment. More the chaotic, more the complex, the better it is. Okay. Do you follow linear thinking? That this is, or your teacher follows linear thinking? You will never become an expert if your teacher said, this is right because I'm saying so. Or a Socratic approach. Why, what, how, when? Should I stop now? I've done enough. So thank you very much, ladies and gentlemen, and I'd like to thank NAM, and you please convey my thanks to him. I'm grateful to NAM and the AIOS Scientific Committee for giving me these few minutes for discussing on a subject which is very, very close to my heart. Thank you. Thank you.
Thank you, sir. 10 minutes doesn't do justice for what Amod sir has to offer. I've heard the longer version of this talk.
Yeah, you heard.
So it's like a sneak peek into the cerebral cortex of a great clinician, how it works. Thank you, sir. Thank you for the talk.